Hello students, I'm Joyce Chenard. I'm filling in for Holly today, and I'm going to talk to you about fluid imbalances. So this lecture is going to go over Chapter 57 in your ATI Fundamentals. The goal of this lecture is to go over dehydration, overhydration, types of fluid, what you're assessing for as the nurse, and then what patients might have these particular issues. So we have two main types of fluid in our body. We have intracellular fluid, which just like the name says, would be fluid that's inside of the muscle, brain, or skin cells. And then we have extracellular fluid, which would be pretty much everything else. So blood, spinal fluid, pleural fluid. Pleural fluid is the fluid that lines the outside lining of your lung and the inside of your ribs, and your peritoneal fluid, which is the sterile fluid in your abdominal cavity. Students, I want you to understand the fluid can move in between these two types of two spaces pretty freely through a semi-permeable membrane to stay in balance. So if you're dehydrated, sometimes what will happen is fluid that is in your muscle cells will shift over into your bloodstream to help keep up your blood volume. And I like to think of it like this. It's like your body's always trying to do yoga to stay in balance. So we call that homeostasis, but your body's trying to stay in balance. This should be an anatomy and physiology review. The fluid moves by these four methods: osmosis, filtration, active transport is used for the fluid to go in between the intracellular and extracellular spaces. So is your patient a grape or a raisin? As we can see here to the left, we have a wonderfully hydrated grapes right here, and then through fluid loss, the grapes became dehydrated, and definitely the physiology of things changed considerably. So being dehydrated, not enough fluid in the body, this is usually one of two things. It's either lack of intake or too much output, fluid loss, or it could be both. So is your patient a grape or a raisin? So what is normal? Well, normally what goes in must come out, but it isn't always urine. We lose every day, every 24 hours, about 600 milliliters every 24 hours in insensible fluid losses. So this would be fluid that we can't measure. And I want you to realize that. So when you, as the astute nurse, you're calculating your intake and output with your patient, I want you to understand that if your patient has 2,000 in and they only have 1,400 out, that's a good thing. That means that they're in balance, because there's about a 600 difference there, and that would be the average for insensible fluid losses. So I want you to kind of commit that to memory also. Obviously, every patient in the hospital is not going to have 2,000 in, but you can use this kind of as a general rule. Whatever they have in, take their output away from that, and it should be about 600 every 24 hours. So going back here to our PowerPoint, you as the nurse, what does your patient look like? The patient here on the left is well hydrated. He's got good skin turgor, he's got good color, he's got great vital signs. His blood pressure is 120/80, has a temperature of 37, which is 98 degrees or 98.6 degrees Celsius. He looks pretty comfortable. He's not in pain. He doesn't appear weak. Whereas your patient on the right is absolutely the picture of what a dehydrated patient looks like. So his blood pressure is 80/30. And if you've been in my clinical, you know that blood pressure does not create a map of 60 or 65 and higher. So this patient is not having adequate kidney perfusion. So he's not going to have urinary output, or he's going to have very low urinary output. He has a high heart rate of 120. He has a fever. He's 40 degrees Fahrenheit or 40 degrees Celsius. And if you look at your patient, he's weak. He's got poor skin turgor. Sometimes they do look flushed because they're dehydrated. His eyes are sunken in. And if you look at his pupils, he's got some pupillary changes. Severe dehydration will cause mental status changes, in addition to headache as well. What else does dehydration look like? So they've got dry, cracked lips, acute weight loss from all the fluid volume loss, low urinary output, a high heart rate, weak pulse. Your weak pulse and your delayed capillary refill, that comes from having low blood volume. If you don't have enough fluid on board, then you don't have enough blood volume. And if you don't have enough blood volume, you're going to have poor capillary refill and poor pulses. So normally, our body tells us when we are low on fluid and we need to get more fluid. It's called compensatory mechanisms. I want you to remember that term. NCLEX likes that term. So it is your compensatory mechanisms that tell us that when we need to consume more fluid. There are three ways that this happens in our body. So write this down: thirst, antidiuretic hormone, and aldosterone release. These are your three compensatory mechanisms. How it works is it's basically your body telling your brain that it needs water. So your first compensatory mechanism, which is thirst, your thirst receptors are in your brain. So your brain can tell you're dehydrated and it tells you to drink more water. So just like this cute little diagram. Over here on the left, it's when he was thirsty and his brain was stimulating that he needs to drink some water. He drank some water, and now that has cooled things off. He got that feedback that he is now better hydrated. Your second compensatory mechanism is antidiuretic hormone. Now, this is a hormone released from the pituitary gland. It goes to the kidney and tells your kidney, I need you to stop making urine because we need to conserve our fluid. So the kidney, being the great helper that it is, it receives the antidiuretic hormone and it gets the sign that it's going to stop making urine because it's going to help. So that is when your patient has low urine output, when they're dehydrated. The kidney's trying to help and it's conserving fluid. Our last compensatory mechanism is aldosterone release. Aldosterone is released from the adrenal glands. Your adrenal glands sit on top of your kidney, and they tell your kidney that it needs to save sodium. And when you save sodium, you in turn save water, because water and sodium are friends and they like to hang out with each other. So your third compensatory mechanism comes from is aldosterone, and it comes from the adrenal gland. Get it? Adrenal. That's actually where the name came from. As you know, in healthcare, renal means kidney, and the adrenal or adrenal gland means that it is on top of the renal organ, or the on top of the kidney. So the adrenal gland releases aldosterone. Your kidney starts to conserve sodium, which then in turn saves water. So this is our adrenal gland. It's releasing aldosterone. It says, hey, we're going to save our sodium and hence save our water. So it is our third fluid regulation compensatory mechanism. Students, I want you to commit this picture to memory. Your patient is supposed to have 30 milliliters of urinary output every hour. That tells me that is the bare minimum. That tells me that your kidneys should be perfusing, they should be functioning, and you should have just enough hydration on board to be able to keep all of your organs functioning. 30 milliliters every hour. So how did your patient get dehydrated? The causes of fluid losses. A few of these you're probably going to be familiar with firsthand. So our first patient, how do you think this guy got dehydrated? Probably ate some food that was less than healthy, and now he has vomiting and diarrhea. So this is a method that we're losing more fluid than we normally would. Our next example would be exercise, heat exposure. Some of you are athletes. How many of you have gotten dehydrated with an event and you have felt weak and you felt dry and you have poor skin turgor, and you probably got a little bit of a headache? Another cause of your patient getting dehydrated is kidney disease. As we just talked about earlier, your kidney has a very vital role when it comes to fluid regulation. It's receiving antidiuretic hormone from the pituitary gland saying conserve fluid. It's receiving aldosterone release from the adrenal gland saying, hey, we're going to save sodium, so hence save water. But if your kidneys aren't healthy, then your patient is at a much higher risk for having fluid regulation issues. And we have lots of reasons for kidney disease. So it could be high blood pressure that's been untreated. Now it's caused permanent damage. You can have uncontrolled blood sugars and it's now caused permanent damage. Your patient can have a kidney infection. Your patient could have a pathological problem that they can't help, a genetic issue, polycystic kidney disease. These are patients who are going to be more at risk for fluid dysregulation issues if they have diseased kidneys. Another reason is we might be making the kidney work a whole lot harder than it had planned on doing. So medications that are diuretics, so like Lasix, Bumex, hydrochlorothiazide, spironolactone, we're making the kidneys excrete more fluid than what they planned on doing. Another cause of, or Another reason your patient might be dehydrated is adrenal disease. So, as we talked about, your third compensatory mechanism, your adrenal glands release aldosterone, and if your adrenal glands are sick, then they're not going to know what they're doing. So, you've got an acute, confused or sick little adrenal gland here, and now he doesn't know what to do with sodium. He's kind of confused, and hence he's not telling the kidney properly. He's not giving him proper aldosterone release, and so our fluid regulation is also off. Another reason your patients may be dehydrated, burns. Burn patients, we have a very difficult time keeping them in fluid balance because burns lose fluid. So you have tissue damage, it's losing a lot of fluid and also electrolytes that way. And so we really have to, they have a lot more insensible fluid losses, so we really have to watch their urinary output and their vital signs. Students also, one of the main reasons your patient's dehydrated, may be dehydrated in the hospital, is surgery, which is why I put this picture up here. Your surgical patients, there's two things going on here that I want you to understand. Our skin is our largest organ, and it has a lot to do with holding fluid on the inside of our body. Okay, so that makes sense. When we're in surgery, we have an open incision, whether it be our chest or abdomen or other locations in the body, and now with that skin barrier open, we are now losing fluid by evaporation. So your surgical patients lose fluid in surgery by evaporation. But also look here on the floor. Our surgical patients lose blood. Now some surgeries do lose more blood than others, but surgeries like your hip and your knee surgeries, those are orthopedic surgeries, those are pretty bloody surgeries. This is also such an important avenue of fluid loss. All of your surgeons, when they document the note for their surgery, they will put an estimated blood loss because it's calculated into how we expect our patients to do afterwards. So surgical patients, they lose it by dehydration and they lose it by blood loss. And then the last patient and obviously there's other, the last patient I'm going to talk to you about is diabetes. Especially if your sugars are uncontrolled, your diabetic patients will lose a lot more fluid than a normal patient. Diabetes actually means to siphon. It's a Greek word, means to siphon. That's actually where the term diabetes came from. So many centuries ago in Greece, they noticed that some people peed a whole lot more, and they said that that person has diabetes, meaning they're siphoning off too much fluid. You have two main types of diabetes. Mellitus means sweet, and insipidus means tasteless. So your diabetic patients are siphoning off more fluid than they should, especially if their sugars are uncontrolled. Your dehydrated patient's labs. So you as the nurse, you're not only going to assess your patient, you're going to check their chart and look at their labs. So as we talked about earlier with our dehydrated patient looking flushed, a lot of times it's because now they have a high hematocrit, high serum osmolarity, high BUN, high sodium. Your numbers are a lot higher because you have less water. So let's go over here to our blackboard and I'll draw an example. So students, here I have drawn a tube of blood here, and those of you who have had a chance to rotate into the lab, this tube of blood, this would be something that's already been spun down. So we've got our RBCs down here. So those are our RBCs. And then up here we've got our serum right up here. So with this tube of blood or blood sample, we've got red blood cells down here and serum up here. So your hematocrit, if you remember from your clinical lab work, is really the percentage of red blood cells in your blood. So if we look at a blood sample, this part right down here would be like your hematocrit. So these are the red blood cells in proportion to the fluid portion of your blood. And so normal hematocrit is usually, anywhere from like 37 to 45. Okay, so we'll write that down here, 37 to 45. That's kind of an average between male and female. So when your patient is dehydrated, they're going to have less fluid, but they're still going to have the same number of red blood cells. So a patient who's dehydrated, their blood sample would look a little bit more like this. So your patient, a dehydrated patient, they're going to have less fluid, so they're going to have less serum, and their hematocrit percentage then is going to be higher. So a patient who has a hematocrit of 50% or 52%, I would know that that patient is dehydrated. They don't have as much fluid on board as what they should for the amount of red blood cells that they have going around in their bloodstream. So the same is with their urine osmolarity. So your urine sample would still have all of the same particles in it, but less fluid. So it would be a higher concentration. So the less fluid means higher concentrations of your samples, whether it be blood or urine or blood urea nitrogen, which is a blood level that we have. Um, this is excreted by the kidney and regulated by the kidney, and if the kidney is conserving things, then it's conserving also as a result of not filtrating. It's going to have more bun on board. So the opposite of that, your patients who are overhydrated, meaning that they have too much water, what do they look like? Here we have a lovely little overhydrated patient. Look how puffy he is. He has got way too much fluid on board. So when you're assessing your patient, what do they look like? They've got edema, they've got high blood pressure because now they have too much fluid on board. So that's making their blood volume larger, so their blood pressure is high. Sometimes their fluid will shift into their lungs where it's not supposed to be, so they have crackles in their lungs. This can be a patient with an enlarged heart with like CHF. And if you've been in my clinical, we've seen this on a couple of x-rays. Your patient might have tachypnea or a high heart rate or high respiratory rate. And then also they can have distended neck veins. So sometimes when your patients are overhydrated, usually from congestive heart failure, when they're laying here in the bed and their head's back, if you look at their carotid veins, the veins or the jugular veins over on each side of their neck, it will actually be enlarged, and you might actually see it fluctuate when you're with your patient's breath. With each breath, it'll change the pressure in their thoracic cavity, and it'll actually push up on their neck, and their jugular vein will go in and out right along with each breath. And so those patients, have too much fluid volume on board. So looking at your patient, you're going to assess them. So you're going to look for edema. You're going to look for jugular vein distension. You're going to look at their vital signs. Is their blood pressure elevated? And you're also going to look at their labs. And so these three things that you're going to assess for, that's going to help guide your plan of care, how you're going to take care of them. So with your overhydrated patient, they're going to obviously they're going to look opposite of what your dehydration patient is. So with your overhydrated patient, maybe we've given them too much IV fluids, and now their hematocrit is artificially low, or their urine is like, it's not yellow anymore, it's like almost clear. So the osmolarity is super low. Low urine osmolarity, low serum osmolarity, low sodium, because they're so hydrated now that the amount of sodium is diluted in their body. So your patient with too much fluid, they're going to have diluted numbers. So coming back over here to our blood samples, as you can see, all of our blood samples are the same amount of sample, and our hematocrit varies depending on how hydrated or dehydrated the patient is. And we look at hematocrit, not so much hemoglobin, but we look more so at hematocrit because it's a percentage in regards to fluid balance. So normally, and I don't think NCLEX is going to go over this much. So normally, like if your patient's hemoglobin is 10, I would expect a hematocrit of, so if your patient has a hemoglobin of 10, normally they would have a hematocrit of about 3 times what the hemoglobin is. So that's normal. So with your patient who has a hematocrit that's really low, but a somewhat normal hemoglobin, I know they've got too much fluid on board. They're overhydrated. So with this blood sample, if a patient has a really low hematocrit, their hemoglobin though is pretty normal, they have got way too much serum. Now if you think about it, your sodium levels, your potassium levels, all of that, especially your sodium levels, that comes from your serum on that blood test. So if your hematocrit is low and your sodium level is low, then you know that this patient is overhydrated. They've got too much fluid. So determining your plan of care with your overhydrated patient, things that you're going to look for is your vital signs, your labs. Um, with your care plan, how many of you have taken care of now a patient in the hospital who has CHF and they have an order to get a daily weight? So your congestive heart failure patients or your patients with too much fluid on board, you're going to get a daily weight on them. And ladies, we know that not all scales are created equal. So we like to have the patient use the same scale, or we'll teach our patient to use the same scale every day so that it's a more accurate reading and we can better assess the fluctuation difference between day to day. We also like you to weigh yourself at the same time every day. Our weight varies throughout the day. So, what we teach our patients, and generally what we practice in the hospital, is we have the patient get up. We prefer, if possible, that they empty their bladder and then we get them on the scale. So, weighing your patient, same time, every day, same scale. So, what is the big deal that we make about weight when it comes to fluid volume status and um, fluid regulation? What's the deal? Because 1 liter of fluid is 2.2 pounds. That is why we teach our patients if they need to contact their provider's office if they've gained more than 3 pounds in one day, because then that's generally a fluid volume issue. And so finally, to wrap this up for just the fluid imbalance portion of our lecture today, the NCLEX, they want you to understand vital signs, what your lung sounds sound like for people who maybe have fluid overload, what the expected urine output is on your patient, what your abnormal labs would look like for a patient who is dehydrated versus overhydrated, and understand that a patient can lose fluid aside from urine, and things to anticipate with that. Hope this helps. Have a great day.